Hello everyone. So today we'll be talking about pharmacogenomics, also known as PGX. So PGX is the study of how an individual's genetic makeup influences their response to drugs. The aim of pharmacogenomics is to optimize drug therapy by tailoring treatments to a patient's genetic profile, ensuring maximum efficacy with minimum adverse effects. It moves away from the one dose fits all model, enabling precise prescribing and reducing trial and error approaches. By using genetic data from genotyping or sequencing, PGX helps predict treatment responses, minimize adverse drug reactions, and improve overall therapeutic outcomes. So, here what we see is the summary of the PGX timeline. So, early foundations were from 1902 to 1962. Genetic links to drug metabolism were established. Genomic research was from 2000 to 2009 when PharmGKB was launched, Human Genome Project was completed, and PGX was added to FDA drug labels. Clinical guidelines were expanded from 2008 to 2015. PGX guidelines for antidepressants, antipsychotics, and carbamazepine were established. Further expansion took place from 2017 to 2021. Pharmacogene databases, CYP-IC guidelines, FDA approved CYP-2C19 tests, and psychiatric PGX advancements took place. Now let's look at a few real life examples of PGX being used in clinical settings. First up would be clopidogrel. So, clopidogrel, why it matters is because it is a widely used antiplatelet drug for preventing heart attacks and strokes. It requires activation by the CYP2C19 enzyme. The clinical action would be genetic testing, helping identify poor metabolizers who should use alternative drugs like ticagrelor and prasugrel. The real life impact was that the FDA added a black box warning and major guidelines recommending alternative treatments for poor metabolizers to reduce the risk of major adverse cardiovascular events. The second example would be warfarin. Why warfarin matters is because it is a widely used anticoagulant for conditions like AF, TVT, and PE, but improper dosing can cause excessive bleeding or blood clots. Here, the clinical action would be again genetic testing, helping determine the right dose, reducing complications. Direct oral anticoagulants, DOCs, are safer alternatives that don't require genetic testings. The real life impact was that the FDA recommended PGX testing, and trials showed that the genotype guided dosing reduced hospitalizations and improved outcomes. Last but not the least is carbamazepine. So, carbamazepine, why it matters is because it is used for treating epilepsy, trigeminal neuralgia, and bipolar disorder. But it can cause life threatening hypersensitivity reactions like Steven Johnson syndrome and toxic epidermal necrolysis. Again, the clinical action would be genetic testing, and it is required especially in high risk populations. The real life impact was that the US FDA, US Food and Drug Administration, and Clinical Pharmacogenomics Implementation Consortium CPIC and the global health agencies recommended genetic testing. In fact, many Asian countries have mandatory genetic screening, leading to a major reduction in severe drug reactions. So, let's revise the key features of pharmacogenomics. First would be being a personalized medicine, improving drug efficacy and safety, influencing drug metabolism, reducing adverse drug reactions, improving precision in drug dosage, providing faster drug development and approval, helping identify disease susceptibility, development of advanced vaccines, optimization of cancer treatment, and last but not the least, cost effective healthcare. So, in summary, how pharmacogenomics works is by genetic testing, subsequently identifying the key genes, classifying metabolism, providing personalized therapy, integrating PGX into healthcare, advancing research, and lastly, as an outcome, enabling safer, more effective, and personalized treatments, reducing trial and error prescribing, as mentioned before. Like any other aspect of healthcare, PGX2 carries its nuances and limitations. First one would be limited genetic data and population diversity. This could be solved by expanding research to diverse populations and creating ethnicity specific genetic databases. Second would be its cost and accessibility. The solution would be implementing cost effective sequencing technologies, including PGX testing in insurance coverage and promoting government funding for genetic research. Thirdly, the complexity of drug gene interactions. This could be solved by developing multi omic approaches like incorporating genomics, proteomics, and metabolomics to improve predictions. Fourth is the lack of physician awareness and training. The solution would be integrating PGX education into medical curricula and providing decision support tools for clinicians. Fifth are the ethical and privacy concerns. This could be solved by strengthening data protection laws like HIPAA and GINA and ensuring informed consent and promoting genetic counseling to avoid any discrimination based on genetic information. Last but not the least are the regulatory and implementation challenges. The solution would be establishing global guidelines and encouraging collaboration between regulatory agencies, researchers, and clinicians.